We have great pleasure in having Professor Vincent Chan from Canada with us. Professor Vincent Chan is the Professor, Department of Anesthesia, University of Toronto, Ontario. Dr. Chan also serves on the editorial board of the Anesthesiology and Regional Anesthesia Pain Medicine journals. He has published over 200 peer-reviewed articles, 14 book chapters, and over 80 scientific abstracts. Dr. Chan has performed more than 70 visiting professorships in North America and abroad, and given over 200 international and 100 domestic lectures. Dr. Chan is acknowledged by his colleagues as an international leader in the fields of regional anesthesia and pain medicine. Presenting to you, Professor Vincent Chan.
Hello, everyone. Welcome to this presentation on new ultrasound-guided techniques for pain relief after knee and hip replacement surgeries. My name is Vincent Chan from University of Toronto, Canada. Thank you for inviting me to speak. I'm really honored and privileged to be part of your meeting. In the next 25 minutes, I hope to describe some of the newer trends for total hip and total knee replacement recovery program, to show you how regional anesthesia can be an effective part of multimodal analgesia. Then we will look at some of the newer analgesic techniques that are available. And these are generally infiltration, local anesthetic injection techniques into the fascia plane or the compartment space. We will review some of the preliminary data that are generally very encouraging, but I urge you all to take it with a grain of salt and look at the data with some skepticism until we have more data. Finally, I hope to provide you with some practice recommendation. I have no conflict of interest to disclose. Fast-track surgery, or so-called enhanced recovery after surgery, ERAS, is a new way to treat patients after surgery to improve patient outcome by decreasing the surgical stress and to preserve post-op organ function. At the end, patient will have an improved outcome due to a reduction in morbidity and mortality. Enhanced recovery program can reduce the length of stay for the patient, and this will end up having significant saving to the hospital and healthcare system. Cost saving to the healthcare system is very important because the cost of healthcare is escalating. Also, as our population continues to grow older and older, the demand of surgery and healthcare will increase. So unless we do things more efficiently, the waiting list may become very longer and longer, and we may not be able to afford at the end. So an enhanced recovery program for total hip and knee replacement surgery follow a very structured, comprehensive, multimodal perioperative pathway. And these interventions begin before surgery, continue during surgery and after surgery, and it touches on a whole variety of surgical care, anesthesia care, nursing care, and others. As you can see here, pain management is an important part of ERAS program, particularly the use of regional anesthesia and the use of multimodal opioid-sparing analgesia. That is a major component of this program. Hospital discharge is the ultimate measure of how effective the ERAS program is. As you see here, for hospital discharge criteria, they are called DREAMS. DR stands for drink, EA stands for eat, M stands for move or mobilization, S stands for sleep, and I added two more: a smooth transition to oral analgesic agents to provide good pain relief, and also to prevent any major complications such as surgical site infection and deep vein thrombosis after total knee and total hip replacement. As you see, for these two types of surgery, the main challenge to recovery is mobilization. And this is why we must control the pain very well to prevent patients having significant nausea and vomiting and dizziness. And any blocks that we do for these patients must not paralyze their lower limb muscles. So this is a good example of a successful ERAS program 4 hours after total knee replacement surgery. The patients are already getting up from bed and walk around with two assistants, one on the side and one person having a chair in the back, just in case the patient needs to sit down. Why is it so important to get the patient up so quickly? Showing the patient that they can walk without pain immediately after surgery has a major psychological impact on the patient for them to gain self-confidence. And the sooner they can walk, the sooner they can get out of the hospital. And to do this, we now no longer use long-acting spinal anesthetic. We use mepivacaine, aimed for a block to about 2 hours. Any regional anesthesia technique we give to the patient aim to have motor sparing analgesia. We give them up to 2 liters of crystalloid to make sure they don't have dizziness. And we are very aggressive with nausea and vomiting prevention using dexamethasone, ondansetron, plus or minus scopolamine patch. Now we have many newer analgesic block options. The surgeons perform local infiltration around the knee, around the joint. We perform adductor canal block and also IPAP infiltration between the space between the popliteal artery and capsule of the knee for total knee replacement. Then for total hip replacement, we have the option of fascia iliaca block, the quadratus lumborum block, the lumbar erector spinal plane block, and also the PANG block, the pericapsular nerve group block. So now we have so many choices. This is like going into the candy store. They're all attractive options. Which one shall we choose? That is the challenge to us right now. So here are my recommendations. I follow a KISS principle, keep it simple and stupid. Start with a simple treatment regimen. If we are not happy with the simple regimen, then either we change what is inside this regimen or add to more treatment to this regimen. The two most important goals, again, we emphasize again and again. Number one is opioid sparing. We want to decrease the opioid-related side effects. Second, we want motor sparing. Anything we do to a patient, we don't want to paralyze the lower limb muscles. We want patients to get up quickly and start rehabilitation as quickly as possible. So what are the simple methods? First one is a physical method. Simply not putting a tourniquet around the knee for total knee surgery may help to reduce swelling. And some surgeons believe that. And in our center, some surgeons are doing it without the tourniquet. And because of tranexamic acid, topical and intravenously given, blood loss is not an issue even without tourniquet. Then we can use ice, cryotherapy, whether it's just a simple pack of ice or use these fancy equipment to reduce swelling. That makes a lot of sense. And finally, early mobilization. By walking quickly, swelling likely will be less and also reduce the incidence of deep vein thrombosis. So start with something simple, and this doesn't cost much money. Second, we can use the intravenous dexamethasone. Since we're using it for nausea and vomiting prevention, studies have shown that a single dose of intravenous dexamethasone, 8 to 10 milligram, can reduce post-op pain, can reduce the opioid consumption, as well as reduce the incidence of nausea and vomiting. Some people ask, is it safe for higher risk patients such as diabetic patients? As far as we know, it's very safe based on large-scale patient registry. The single dose of dexamethasone will not increase the incidence of surgical site infection. Next, we move on to something simple, oral multimodal analgesia. We start with non-opioids, acetaminophen or you call paracetamol. We also use celecoxib, which is one of the COX-2 inhibitors, around the clock to provide baseline pain relief. Some centers still use gabapentinoid. We do not use that anymore. We do not use it routinely anymore because we find a high incidence of sedation, in some cases of respiratory depression, so we stop. We only use it only as necessary. If non-opioid drugs are not enough, then we start low dose, more potent opioid agents. We do not use intravenous PCA anymore, only as a rescue, but not routinely. And also we do not use a control release opioid, and this is reserved only for patients on chronic opioids. Then we come to the easy, simple to do regional analgesic technique, such as local infiltration analgesia or periarticular infiltrations of local anesthetic. In our center, we find it's highly effective. Surgeons universally do this very well, injecting local anesthetic around the capsule, in the fascia plane, in the muscle, and the soft tissue. Our recipe is to use 0.2% ropivacaine, which is commercially available. Use up to 100 to 150 mils, 100 for one knee and 150 mils for two knees. We add a ketorolac 30 milligram and epinephrine 0.6 milligram. I know that in some centers, they also add dexamethasone or other type of steroid and opioid into the mixture. In my clinical practice, I find that local infiltration for the knee seems to work better for the knee than the hip for some reason. I ask my surgical colleagues why, and they cannot give me an answer. There are now many randomized controlled trials showing the effect, the beneficial effect of local infiltration for hip and knee replacement patients, and we thanks to Dr. Kerr and Dr. Cohen in Australia, who first described this technique. Then we talk about something that you may not do. We have been adding low dose intrathecal morphine to the spinal anesthetic solution, up to 0.1 milligram in these patients, and we find it's very effective. I know a lot of people worry about the side effects. We only monitor these patients on the ward. We do not find any high incidence of respiratory depression. As you may be skeptical, but in this randomized controlled blinded study, when we add intrathecal morphine to local infiltration plus adductor canal block, we find that it further reduced the pain score, the opioid consumption, and particularly when we look at the side effects, nausea, vomiting, pruritus, urinary retention, we do not see a difference. So in our experience for now over 8 to 10 years, we find it's extremely safe. Most recently, we did a review on more than 1,300 patients. These patients have documented obstructive sleep apnea, and using this dose, low dose up to 0.1 milligram, we do not see any increased incidence of respiratory complications. So in our opinion, it's a very safe and effective way to treat pain. As I said, most of the peripheral blocks that we do now, the goal is motor sparing. And we realize that for conventional methods such as lumbar plexus block for total hip surgery and femoral nerve block for total knee replacement surgery, they will definitely, a good effective block will definitely paralyze the quadricep and will impair their rehabilitation early on after surgery. We have tried very hard to change the local anesthetic type, the dose, the concentration, volume trying to improve the motor sensory separation, and we fail. For this reason, we need to change our technique. So these are the newer analgesic, regional analgesic techniques. You can see that they really have two purposes. The first one, you put the local anesthetic a bit farther away from the main trunk of the lumbar plexus or the femoral nerve, such as the quadratus lumborum block, the fascia iliaca block, and the adductor canal block. So the aim is to put the local anesthetic a little bit farther away from the main trunk of these nerves so that you can get more sensory than motor blockade. The second approach is to put local anesthetic as close to the joint capsule as possible. The PANG block and the IPEC block are blocks that simply block the sensory articular branches to the joint without affecting the motor fibers. And this is another way to achieve motor sparing. First, let's look at the adductor canal block for a total knee replacement. We know that we do this block to control pain in the front of the knee by blocking the branches of the femoral nerve. Realizing nerve to the vastus medialis muscle is an important innovation to the anterior capsule. Many randomized controlled trials have confirmed that the adductor canal block in the presence of multimodal analgesia is as good as femoral nerve block. The pain relief is just as good, and at the same time, it does not paralyze the quadricep muscle. There are many debate about where to put to inject. Personally, I tend to inject high up, close to the apex. This is essentially more like a femoral triangle block, and my landmark is to put the femoral artery in the midpoint of the sartorius muscle. This is an easy block to do, perivascular compartment block, and 20 mils of local anesthetic will spread the long distance, and again, without any motor blockade. Then we talk about the IPEC block. Injection in the space between the popliteal artery and the capsule of the knee. This is to block the articular branches of the sciatic and the obturator nerve by injecting a wall of local anesthetic, usually 15 to 20 mils of local anesthetic above the femoral condyle. Initial experience shows that when this block is added to the adductor canal block, it further reduces pain score. It can improve range of movement and the ambulation. Dr. Sanjay Sinha is the first one to describe this block technique. I refer you to his excellent paper published last year. As with any new block technique, the initial experience is always positive, but subsequent studies, 3 recent randomized controlled trials, show no further reduction in pain score or opioid consumption. So the jury is still out for the IPEC block at this time. Next is the suprainguinal fascia iliaca block. Simply by doing the block above the inguinal ligament, simply by putting the probe obliquely like this, and the landmarks to observe above the muscular landmark is the anterior abdominal muscle, inferiorly is the sartorius muscle, so-called the bow tie sign, and then below is the iliacus muscle. Covering the iliacus muscle is the fascia iliaca. So by injecting this way, injecting 30 to 40 mils of local anesthetic this way is more likely to push the local anesthetic towards the branches of the lumbar plexus, and this block will anesthetize lateral femoral cutaneous nerve and some branches of the femoral nerve. Dr. Hubbard was first to did a cadaver study to look at the mechanism of this block. Studies show that it does reduce morphine consumption for total hip surgery. Doing a suprainguinal injection is better than infrainguinal injection because the local anesthetic is spread more consistently towards the lumbar plexus. There are a number of meta-analyses now showing the beneficial effect, but just like any injection close to the femoral nerve, there is a chance of a motor blockade, so something to remember. Next, we look at quadratus lumborum block. And this block is done by using the quadratus lumborum muscle as the reference point. As you can see here, the injection now is high up, moving from the iliac bone and now to the L4 vertebral body level. You can put the bolus of local anesthetic in front of the quadratus lumborum muscle, anterior approach, on the side of the muscle, lateral approach, or behind the muscle, posterior approach. But more and more people are now doing the anterior approach. As you can see, injection of local anesthetic here will block branches of the lumbar plexus, such as the ilio, hypogastric, ilioinguinal, lateral femoral cutaneous nerve, and also hopefully some part of the femoral nerve. In a cadaver study, dye injection study, the L1, L2, L3 nerve roots are often stained by the dye. So this is likely the basis of the analgesia for total hip surgery. Again, a number of randomized controlled trials have been conducted to show the beneficial effect of this block, decreasing pain, decreasing opioid consumption, and possibly shorten the length of stay. Now, whether quadratus lumborum block is as good as fascia iliaca block, at this time, one study shows that they are equivalent, but it's reported as an abstract last year. There's also one case report showing that surgical anesthesia is provided with the when we combine this block, quadratus lumborum and fascia iliaca, for revision of the total hip. Again, there is a small risk of bolter weakness when you put local anesthetic close to the lumbar plexus. There's a chance of lower limb weakness. Next new block is the lumbar erector spinae block. And this is not surprising since the erector spinae muscles starts from the neck and goes all the way down to the lumbar spine. So anywhere between the neck, the thoracic spine, and lumbar spine, you can inject local anesthetic. And the group from Turkey use the L4 transverse process as their landmark, inject local anesthetic, 20 to 30 mils of local anesthetic, and flood the erector spinae plane. And they were able to show that this helps with pain relief after total hip surgery. How does it work? Just like the thoracic erector spinae block, the injection in the erector spinae plane will spread anteriorly to the paravertebral space, some into the epidural space, and in this case report, they also find that it spreads towards the lumbar plexus. And this is an interesting case report showing that this is the main surgical anesthetic technique for elderly patients under hip surgery. And the contrast dye is shown to spread between T12 to L5 when the injection is at L4. Then we have the pericapsular block, initially described for hip fracture. As you see here, the bony landmark is the anterior inferior iliac spine, and the IPE is the iliopubic eminence. The muscular landmark is iliopsoas muscle, and the bright area is the psoas tendon. The injection is usually an in-plane technique, and injection of 20 mils of local anesthetic deep to the psoas tendon above the superior pubic ramus will block the articular branches of the femoral nerve obturator and the accessory obturator nerve. So this is how it works. From hip fracture, clinicians are now using it for total hip replacement surgery, and there are case reports and retrospective reviews showing that it works. But right now, we do not have any good randomized controlled trial to show that it works consistently. Also, important to remember, as a needle is going from lateral to medial, look out for the lateral femoral cutaneous nerve and not to hit it accidentally. Also important to remember is when the injection is superficial, too superficial, there is backtracking of the local anesthetic that will get to the femoral nerve block, femoral nerve accidentally. As far as total knee surgery is concerned, these neuroanalytic block are not used as frequently. For suprainguinal fascial block, only a few studies. For lumbar erector spinae block, again, very few study, mainly case reports, and I cannot find any lumbar quadratus lumborum block for total knee replacement surgery. Now, finally, I want to add a word of caution for all the new blocks. I take this study that I was involved in as an example. Ideally, all these new blocks should be applied for patients having moderate to severe pain. So first is the indication. In this study, even with no block, the patients are having relatively low pain score, 3 to 4. And if you look at the block versus no block, the difference in pain score is about 1 or slightly more than 1. So you ask yourself, is this really important? And then you look at the opioid consumption. This is oral morphine equivalent. You see a difference about 10 milligram of morphine orally. That is equivalent to about 3 milligram of morphine IV in 12 hours. And you ask yourself, is this important? So my message is that just because the results are statistically significantly different, the effect may not be clinically significant. And this is why we urge you all to look at the minimum clinical important difference that in pain or opioid consumption that matters to the patient. Also, in my opinion, any new block technique is not just a matter of betting the placebo, it's not just a matter of better than multimodal analgesia that we use routinely, but most important of all is when we add the new block to what we do routinely, does it provide additional benefit? So in summary, all these new blocks are easy to learn, easy to do, and are very safe. Most of the evidence to support its use are now mostly in case reports and retrospective review. We need a lot more randomized controlled trial to show the benefit, particularly for the new blocks such as IPAC, fascioiliac block, quadratus lumborum, and the PANG and ESP block. I know that we are eager to do this block. If we are going to do it, please follow our block results. Check and see whether we are able to provide any benefit to the patient. Not just a matter of putting the needle in, but we must look at the block results. Also, if it doesn't work well, ask ourselves, is our technique optimal? Should we do it routinely or only do it as a rescue? For total knee and hip surgery, I suggest we stay with the basics, easy analgesic technique, low infiltration. I add spinal morphine, low dose, non-opioid, multimodal analgesia, and also physical method. For total knee replacement, I will continue to do adductor canal block and an IPAC. Now, for the total hip replacement, all the new blocks, I do not know which one is going to be better, whether one is better than the other. We still need to wait for more objective randomized controlled trials to help us to decide. So this is the end of my talk, and I hope that you will be able to ask some questions later on, and this is my email address, and please email me later on after the meeting if you wish. Thank you.